I'm not billing this to insurance, I'm paying.
I don't think you have to fill that out then. You could just put like private pay or something.
I just wrote self.
Yeah, you could write self.
Hey, writing a book?
I don't know. First of all, I can't even come with my dang on wallet.
My name's Hugh.
Trey Kay.
Nice to meet you. Let's go for a walk.
Let's go for a walk. Hey, it's Trey, and that's Hugh Murray. He's a physical therapist, and he came recommended from a childhood friend of mine. I'm not at his office to interview him for this show. I'm here because, well, my knee hurts.
Okay, now, I want you to walk forwards on your toes. There's that again.
I've had this leg pain for years. Sometimes I'll be walking and then all of a sudden this sharp pain shoots through my knee. Sometimes it even happens when I'm just sitting around. To me, sometimes going to the doctor for answers feels a little more like gambling than I'd like. You pay thousands of dollars for x-rays, MRIs, and specialist appointments. Maybe somebody finds some answers. Maybe you cruise through without having to sit on hold with your insurance company. Or all you get is the bill, which can sometimes be a big surprise. It's obvious that COVID did a number on our healthcare system. I'm grateful that I can afford health insurance. But in my home state of West Virginia, many rely on programs like Medicaid for their doctor and clinic visits. Medicaid is a joint federal-state program that provides health coverage for people with limited income. When the government declared the pandemic a national emergency, lawmakers changed Medicaid eligibility so more people could qualify. But right now, Medicaid is going through a major shift. Almost a year after the national emergency ended, we're witnessing the disenrollment of millions from Medicaid. And here on the show, we wanted to better understand how that's affecting West Virginians. I'm Trey Kay, and this is Us and Them from PRX and West Virginia Public Broadcasting. Today, we're asking, how does our society go through a global pandemic and come out on the other end with less healthcare access rather than more? Tricia Brooks is a research professor at Georgetown University's Center for Children and Families. Her bread and butter is parsing out the nitty-gritty details behind Medicaid access. She explains how Medicaid coverage changed under the pandemic.
Well, the first thing to recognize is that the COVID pandemic was a dual crisis. It was certainly a healthcare crisis resulting from the coronavirus, but it also sent the country into a tailspin. And what happens during economic downturns is that many people either lose their jobs and their health insurance, or they have fewer hours, they don't have the money to afford health insurance. So enrollment in Medicaid and CHIP, our country's public health insurance programs, increase. That's generally when Congress will step in by boosting the federal funding for Medicaid.
Before COVID, it was the government's job to check that people who are on Medicaid still qualify year after year.
Sometimes they access data like quarterly wage data from the Department of Labor that says, oh, this person had an income increase. You better check and see if they still have Medicaid. So there was constant, rechecking of eligibility.
But once COVID began, you may remember lawmakers passing a flurry of safety net legislation, including the Families First Coronavirus Response Act, which boosted Medicaid access. And in moments of crisis, federal aid money comes with strings attached. COVID was no different.
And it generally means that they can't reduce eligibility levels or make it harder to enroll in coverage. But this time, Congress went further than it has ever gone before. They recognized that the importance of access to health care was important here because of the many unknowns of COVID. And so they required the states to keep Medicaid enrollees continuously enrolled until the end of the public health emergency.
Take a look at this chart. It shows the number of Americans who died from COVID over the past 3 years. After all the peaks, the deaths are finally trending down.
The White House is just now saying that the president has just signed a bill that will end the national emergency declared during the COVID pandemic.
These days, we're in a strange new phase of the pandemic. COVID continues to affect life in America, but in more chronic ways. Now we have waves of the virus that come and go. Millions of people have long-term symptoms, yet the virus is no longer considered an emergency. And with that comes what experts like Tricia call the unwinding of COVID-era Medicaid. That's a delicate way of saying many people are losing their health care coverage.
It depends on whether you look at actual disenrollment numbers from states or if you actually look at the enrollment trend. Because remember that enrollment's an in and out. People go out, new people come in. And so just because we lost 1 million people doesn't mean Medicaid enrollment dropped by 1 million. When you look at Medicaid enrollment, which is the actual determinant, you will see that we are down by about 8 million people overall and over 3.5 million children.
Here's another way of thinking of those numbers. If every citizen of West Virginia and Kentucky were to lose their health care, that's still fewer people than the number who are getting kicked off of Medicaid. But the government cracking down on enrollment isn't new. Like many safety net programs, Tricia says Medicaid is vulnerable to the push and pull of politics in Washington.
In 2018, there were efforts made by the administration at that time to have a chilling effect on Medicaid. And Medicaid enrollment for kids dropped by 1 million kids. And at that same year, the uninsured rate for kids went up by 0.5 percentage point. We'd gotten down to about 5% uninsured kids. If we've lost 3.5 million, we're talking about another 50% increase in the share of uninsured children in this country. And that would be a real travesty after decades of working to try to bring health coverage to almost every American child.
West Virginia is routinely one of the top 5 states for Medicaid usage across the country. More than a quarter of the state's residents rely on the program for their health care. Medicaid pays for 3/4 of West Virginia's nursing home residents, and nearly half of the state's K-12 students use Medicaid to pay for their annual checkups.
Our community health center system across the nation is very strong. It's not funded sufficiently, though, to provide services to the uninsured, and not all uninsured people know that there's a community health center that they could go to and either get free or reduced cost care. Hospitals have to provide emergency care, but if my child's uninsured and the kid has an episode of asthma and we go to the emergency room and we get them on a nebulizer, maybe we go home with a prescription that needs to be refilled every month. If I don't have a way to get that prescription, I can't go to the hospital and get follow-up care at the hospital from a condition that I saw in the emergency room. If a child breaks a bone and goes into the hospital, that doesn't mean that anybody's going to take the cast off the kid's arm.
When Tricia talks about community health centers, she's talking about a specific kind of doctor's office. That's a federally qualified health center. They exist to give low-cost care to people in need. In West Virginia, Cabin Creek Health Systems is a major healthcare provider for Medicaid users. And Cabin Creek's name is steeped in local history.
It was a group of coal miners. At that time, there were like 5 local unions on Cabin Creek itself. Those miners came together and asked for help from their international union to improve healthcare access for them as miners and for their families and neighbors.
That's Craig Robinson, the organization's director.
We now have 6 community health center sites and 5 school-based health center sites in Kanawha County. So we see a broad spectrum of the community, from professionals to unemployed to people on Medicare and Medicaid, people with private insurance. There's that part of what we do. The other thing is that we're responsible for knowing what's going on in our community and responding to the health needs that are brought to us. One of the responses that we had was to develop an addiction program to address the problem of opioid addictions. We're seeing now about 20,000 patients, different patients, every year. People that see us at least once, it's 20,000 people, about 70,000 patient visits. Of that, about 35 to 40% are on Medicaid.
Federally qualified health centers can get grants from the government or elsewhere to operate. But clinics struggle to break even and even lose money on Medicaid patients. Add that to a new wave of patients being taken off Medicaid rosters, and they're on the phone a lot trying to get people covered. Jake Van Horn is a psychologist and community impact officer for Cabin Creek.
Our observation is that most of the folks that we had that left Medicaid in the enrollment are still eligible. It's that their address changed because any number of reasons. So it's things like I've moved, or I've got a child that now lives with me that didn't used to live with me, or I work, but it doesn't earn me enough to even qualify to not be in Medicaid, but my job changed and I didn't update that. So if basically you have any type of clerical anomaly over the course of the 3.5 years that the emergency was in effect, those all caught up with you at once.
The important thing to understand here is that Van Horn isn't describing an eligibility issue for many folks. This is about paperwork.
They suspended all of those requirements to take pressure off of themselves so that they didn't have to continue to do that while they managed the emergency, and to make sure that folks maintained coverage as they would need coverage if they were to catch COVID-19. So in that suspension, though, it allowed people to maintain care where they typically would have lost it annually anyway.
But now that the emergency is over, Craig Robinson says the state agencies are cleaning up shop.
The Kaiser Foundation, Kaiser Family Foundation, has done a really good job keeping track of this disenrollment that happened after the end of the COVID emergency. And what they say about West Virginia is that we have disenrolled 128,000 people. 44,000 of that 128 because they were determined to be ineligible. In other words, they actually went through a process where they determined these people are no longer eligible. But to me, the interesting thing is that about 80,000 people of the 128,000 people were actually disenrolled without any determination of their eligibility.
In West Virginia, a single person has to make no more than about $20,000 to qualify for Medicaid.
And for the people that are eligible by virtue of the Affordable Care Act, that's really all they're looking at is their income. If you're an elderly person getting a Social Security check and you're living with your daughter and her 2 kids, your Social Security check counts toward the income of that household, and it's counted even though they're kind of 2 separate entities within that household.
And that's when Cabin Creek's director, Craig Robinson, slides this document across the table. It's a 14-page application. The government sent it to Medicaid users as the health emergency ended. People were supposed to fill it out and send it back, and then the government would decide if they could stay on Medicaid.
Whoa. Let's look at that. 14 pages.
And it's not good language. It's a confusing set of documents.
I've actually tried to complete it myself, and I couldn't get through it because I couldn't understand what they were asking for. They want to know about the situation of everybody in the family, including their medical situation. They want to know about your assets, and I had no idea that assets mattered in terms of Medicaid eligibility. I thought it was all income, but they're asking for, what's in your checking account, what's in your savings account kind of thing. How do I fill this out in a way that I don't mistakenly declare myself ineligible?
I mean, I'm looking at this form here. I'm thinking that I would have some type of an attorney or some type of specialist who would fill this thing out. This is like getting somebody to do your taxes or something like that, right?
That's right.
Yeah, but you don't have the resources for someone to help you with that.
Well, you're making a face there.
There's not a lot of integrity to just dropping that in an envelope and sending it to somebody and, in good faith, fill this out, get it back to us, we'll take care of you.
Katie May is in the conference room with us, sitting near Jake Van Horn. She's a psychologist and the clinical director for Cabin Creek's Comprehensive Addiction Recovery Program. Frankly, a lot of May's patients don't have time to parse through 14 pages of legalese.
Some of them might be experiencing homelessness. And I was thinking, I was on Medicaid during graduate school and just graduated a while ago. And so when they started doing these annual reviews again, I was getting call after call from Medicaid to do my reviews. And I was thinking, how are my patients missing these reviews? They won't leave me alone. But it's also a privilege that I've had the same phone number for 15 years and that I have an address forwarding they were able to keep up with me. Some of my patients, for various reasons, have a different cell phone number every couple months, whether it's their phone is being stolen, they're losing their phone, they can't afford a service and are having to change services. So yes, their main focus is not to fill out this 14-page application, but that's even if they get it, if they're being able to be contacted in any way.
So there's like a real circular irony with this entire process. Folks are getting procedurally disenrolled for things like their phone number being incorrect or their address being incorrect, but that's also how they're getting notification and information about how to re-enroll. So you've identified that the address is a problem, but then you're sending the packet to the address that you know to be a problem.
And then my patients are coming in, and the first time that they're finding out about this is us telling them, oh, it looks like your Medicaid is expired, and then there's panic, of course, because that's how they get their treatment. That's how they get life-saving medication. So to be honest, we may know how many people in our system, we may be able to find how many have lost Medicaid, but there may be a large portion that have just not come back because they know they've lost Medicaid and they can't afford to come in. They think they can't afford.
And Jake Van Horn says a major part of Cabin Creek's care is providing medical treatment for substance use disorders.
Anytime that you have a substance use disorder treatment program, it has a higher than average attrition rate. Folks come to treatment, they leave treatment, they come back to treatment. It's kind of a remitting condition. It's a symptom of the condition.
But it doesn't sound like this is helping.
No, because it actually adds this extra variable that we have no ability to really interpret. Folks are already taking a huge step outside of their comfort zone, even coming and seeing us. So anytime you add another barrier to that, it can be insurmountable.
To the patients here at Cabin Creek who just get their health services met by Cabin Creek and their Medicaid is cut, what do you say to them? Sorry, Charlie? I mean, what?
Well, no, we don't turn away people because of an inability to pay. That doesn't come into our calculations
But how long can you maintain that?
We maintain it. That's our job. We maintain it all the time. We do or continually maintain that. And that's in part because of federal grants that community health centers get in order to make care available to everybody. So it's kind of a backdoor way of providing some limited coverage.
Craig Robinson says it's not uncommon for federally qualified health centers to run on razor-thin margins. After all, they are nonprofits. It's a burden when a clinic suddenly has to pay for a patient's prescriptions. Maybe you've heard stories about people rationing their insulin or heart medications. But a lapse in substance abuse treatment is also a life-threatening public health issue. One relapse can kill somebody. On the other hand, Van Horn says that same person's recovery has a butterfly effect.
It's extremely short-sighted to think that the upfront or initial investment in something like Medicaid doesn't pay you dividends in the long run. People, a community being better put together, having better health care, creates better employees, creates better employment opportunities, creates growth, creates better parents, creates better kids, creates better caregivers. People not struggling so much to maintain basic health does create a more advantageous society. It's also really difficult for me to imagine a world where somebody as a child, whenever they're supposed to know not to misbehave or whatever the assumption would be, or whenever they should know that they have to do better in order to have good health care, that they would say, I don't want that. Life is full of these little itty bitty moments and these circumstances that are outside our control, or these tiny choices that don't feel like big choices in the moment, but then they get bigger over time, or the outcomes of them get bigger over time. The consequences aren't related necessarily to the initial set of knowledge or events or whatever. Nobody woke up and is like, whenever I grow up, I'm going to be super addicted to opiates. That wasn't their life plan. So all of these series of events took somebody to a place. The question is, do we leave them there, or do we provide them any level of resources to improve that situation? Parts of me, and whenever I hear people's rhetoric, it's that we've done extra for 3 years, so now we have to make up for that by doing less. It's not real easy to do it with normal. Normal's not that great.
Hearing the Cabin Creek staff talk makes me wonder, in a world where healthcare workers didn't have to, in their words, beg for their patients' coverage, what would they do with that time instead? First, Katie May, and then Jake Van Horn.
I think in a kind of a larger sense, I think about any time that we're not having to deal with basic survival needs, and healthcare is a basic survival need, we're able to thrive rather than just to survive. So I think that just counts for not just a person by person basis, but as a system. If we're not just having to focus on making sure people are surviving, we can make sure that they're thriving or getting to the next step in terms of doing better in their lives.
So if I weren't dealing with Medicaid, I would deal with food insecurity or housing insecurity or, a work program, like us finding folks employment. And I mean, there's 100 issues. If we're just talking about substance use disorder, there's 100,000 issues that we just largely blanket into this thing called social determinants of health. And so we would be able to continue to address those, or we'd be able to build programming that would be preventative and not receptive. So we could maybe address diabetes or heart disease before someone had diabetes or heart disease. So anytime you free up any energy, you can then reinvest it somewhere else.
The importance of Medicaid isn't just limited to getting coverage for the doctor's office. The program provides health coverage for nursing home residents, home health visits, and more. Coming up after a break, we'll hear what happens when that coverage goes away. You're listening to Us and Them. This show is supported in part by the West Virginia Humanities Council and the CRC Foundation.
Music lifts us up and brings us together, even when we can't get together in person. Mountain Stage brings you live performances on the air, online, and in our podcast. They remind you how it feels to be in a live audience listening to live music. This is Larry Gross, host of Mountain Stage. Find a link to our stations and our podcast online at mountainstage.org.
Welcome back. I'm Trey, and this is Us and Them from PRX and West Virginia Public Broadcasting. Today, we're looking at one of the nation's safety net programs, Medicaid. It provides health coverage for people of all ages from households with limited incomes. Medicaid coverage expanded during the pandemic. But now, with the end of the COVID health emergency, states are reviewing who's eligible for the first time in years. It's true that publicly funded medical insurance opens the door for a lot of Americans to take care of their health. Deidre Toppings would know. She lives in Branchland, West Virginia, and works for her local public school system. But 8 years ago, she wasn't working at all. That's when Deidre started having really bad headaches. Sometimes she had vision and hearing loss, dizzy spells. It was scary.
I'm not one to go to the hospital a lot. I mean, I will go to the doctor, but I don't like going unless I absolutely have to. So I just suffered. I mean, I kept getting diagnosed with just chronic migraines, and they tried multiple different medications to help with the migraines, but nothing was working. So then that's when they suggested the further testing with the MRIs and the CAT scans to see what else was going on.
Testing showed a cranial malformation that required an operation. Surgeons needed to remove a piece of her skull to give her brain more space. It's a major procedure, brain surgery.
And then that decompression surgery failed. The base of my brain is outside of my skull again, but am not able to take that much time off, nor money-wise, to have another surgery. It fluctuates because it all depends on how the base of your brain is setting at that point with the spinal fluid flowing around it. So if you're having a bad day and your spinal fluid is not flowing, you have more symptoms and they're more severe. And most of the time when you have those severe symptoms, you're stuck at home because you just can't function. We were very thankful for Medicaid because it would pay for what the 20% that our insurance wouldn't cover. Just medication and stuff because, copays on medicine, they range from anywhere from $5 to some are in the thousands of dollars, even with a copay.
Eventually, Deidre and her husband decided they needed more income. So she got a job. But then, when COVID struck, she got laid off and found herself back on Medicaid. In terms of health care, she says that actually turned out well. She could go to a doctor without having to worry about a huge bill. And her kids were covered too.
It's not something that I want to rely on, but it was nice to have that extra help so that we wouldn't have to take away essentially from our kids because the money that we have to put out for that's coming from groceries or our bills or, something because we don't make a whole lot of money.
Now, we all know what happened next. The pandemic emergency ends, and now Deidre has two new challenges. First, in West Virginia, state employees get fined if they don't use their employer-based health insurance. And second, Deidre and her husband are both working, so they don't qualify for Medicaid anymore, even if the school district's insurance doesn't cover her specific needs like Medicaid did.
We have to budget it, and some months if we don't have doctor's appointments or anything planned, then, we're able to really know what we're going to have to spend. Of course, we put back every paycheck kind of a savings account. That way, if an emergency does happen, we have a little bit. It might not be enough to cover what we need, but we have a little bit put back to help with that emergency.
Deidre is the only member of her family whose health needs monitoring. She's supposed to get 2 MRIs a year. With her current plan, she pays $900 a pop. Do you have somebody who helps you navigate your healthcare and your healthcare coverage? Or is that something that you basically navigate all on your own, you and your husband?
No, we just do it all on our own. It's not something that is fun to think about. I feel like we're being punished because we want to work and we want to better our lives and make sure our children have what they need. When I didn't work and we didn't want more for for our lives. We would get the Medicaid and it would help with the hospital bills, the doctor bills, whatever. But because we both want to work, I mean, we do not make a ton of money. We don't have extras. We don't have all of this stuff. It just kind of feels like we're punished because when we work, then we don't get the help that I necessarily need for my health.
We heard from folks at Cabin Creek how much a simple clerical mistake can cost patients and their doctors. But in Deidre's case, the system is working exactly as designed. Medicaid is meant for America's poorest households. And while her family may not be in the lowest percentiles, COVID-era policies gave Deidre's family a taste of stable insurance that actually worked for them. This is a pretty common story. And as Medicaid returns to business as usual, people are losing resources that made their lives better. When I started working on this story, I thought Medicaid mostly paid for clinic visits and hospital stays. But it's also a major provider of home health care to people with disabilities.
Come on. You're going here with Mom. Get on in there, boy.
That's James Hairston. I just pulled in his driveway in St. Albans, West Virginia. He's ended up in a tough bind, and you can explain a lot of it with just one line.
You always do what you're told. If you don't do what you're told in the coal mines, then you don't work there.
James and I sit across from each other in his living room. The modular house is full of knickknacks that could use a tidy-up. When we get settled, he leans his cane against the couch.
I am a retired coal miner. As far as retired go, I'm disabled now due to a mining injury as of 2018.
James is a real straight shooter. And right away, this 63-year-old is ready to map out every twist and turn of his story.
My dad always told me, he said, anything worth having is worth working for. When I was 18 years old, I told my dad, I said, I'm all man now. I pointed to that house. He said, you can have that house over there. That's yours. Keep your utilities on. You work. I said, yes, sir. He said, every now and then I'll let you come over here and have some dinner with us. But he broke my plate, like I'd go in that cupboard right there and get it. He broke on it, and he said, now you stand on it. And I've been standing ever since. And what my dad instilled in me, I love him with all my heart for it. Yes, I've always stayed in shape, and took care of myself. And, and even back when I first started in the mining industry, there was times where you'd be so far underground where after you worked your 9, maybe 12 hours, you had to walk all the way out. That's 4 to 5 miles after you've worked all day. Sometimes.
Is that all underground?
Yes. Okay. Yes, and if you couldn't walk it, you couldn't work in the coal mines. It was like, I think maybe an hour into my shift, my boss had told me, he said, we're not running right now. He said, go over and help the roof bolter. So what I was doing, I was holding up a piece of mesh wire. The mesh wire is where we were bolting the ribs.
And when you say the rib, that's the structure that you make so it's not going to be a collapse.
That's just like that wall over there. That would be considered as a rib. This would be the roof.
So you're pointing to the wall, like
the wall, like my wall there. That is a rib. I was holding mesh up, and the roof bolter went in at a 45-degree angle. Next thing I know, I had 1,800 pounds of sandstone and coal fall on top of me and pin me to the mine floor. My hands, they were stuck in the air, and all I could do, when I look at them, they would just turn back and forth like this. And I hollered, oh, God, get it off me, get it off me. And as you can see, that right there, that's the results of my mining hat.
Wow, it's like split.
Yeah. That's your lifeline right there. A lot of young guys, they want to take, when they get in the mining industry, and they want to cut their straps. If I'd had them straps cut, I wouldn't be sitting here talking to you. It would have took me away from here. Turned 59 on the surgery table, which I stayed in the hospital for like 1 month. Had to learn to walk all over again. I've had hardware put in me, pins, screws. I've had 3 discs from a cadaver.
What, put into your back?
into my neck. It cut me here, took all this out, laid it on the table, reconstructed it. I went through I went through, a year and a half of rehab, not including the rehab I had in the hospital, because right after my surgery, the next following day they come and got me up, showed me how to transfer from the bed over into my wheelchair. I had to get in between the parallel bars and learn to stand and hold myself up and walk. I had a walker. I'll walk like maybe from here down to your car and turn around and walk back. I began to just build and build and build. There was no quitting me. I have a drive in me to where I'm not a quitter and I'm not a slacker. And that's just me. And that's the way I've always been.
Well, I can attest that a little bit because you and I played on teams in high school, and so you were always a standout athlete back in the day.
Yeah, thank you.
What's this other stuff that's on the ground here?
That there, that's my rock hammer, that's my crescent wrench, and those are my channel locks. That's my SCR 100. That's my self-contained self-rescuer. That's on my belt at all times. In the event of an emergency, I can take and drop to a knee. I can pull that apart and don it and put it on, and I can walk, say like wherever the next break of what anti-shake cases are with these self-contained rescuers, I can go to them and get me another one. But that has 1 hour of what air in there? Oxygen, goggles, and a nose clip. Yeah, you pull a rip cord, and it's supposed to deflate a bag in the bottom. You have 1 hour of air. A lot of times you can pull them, they won't deflate out like that. And what you do, you just take and blow in the hose, and that'll start it. And what it does, you put the hose in your mouth, it'll get real warm. What it does, it seals around your mouth so there's no leaks. I'm a trained EMTM underground. I have certification in it. I can run just about every piece of equipment underground, from a 1212 to a 1415. I can run a shuttle car. I can run a scoop. I can run a roof ranger, roof bolter. I can pin top. And there's nothing that I can't do underground, and I've always done what was asked of me within reason.
So when you were mining coal, what was your plan for retirement? What was your plan then?
My plan for the retirement was to work until I couldn't work anymore, and it was time to carry me to Boot Hill. That's how much I loved it. You got to like what you do, and that's what I was into, and that's what my father had done, my uncles had done. And if it was good enough for them, it was good enough for me. My uncle worked 44 years at Carbon Fuels. My father worked at Cement Savi, which now is what they got the state penitentiary built over top of what used to be a big union mines called Cement Savi, Mount Olive. I'm just a country boy, and I'm proud of who I am and what I am. But the disabilities that I have, there's nothing I can do. I can't even bend over. I bend over, it hurt. Sometimes I bend over to tie my shoes and stand up and it's just pop, 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 pop. Sometimes it feels like it's just bone on bone, and I just hurt.
Both James Hairston and his wife Leah are disabled. He used to get Medicaid benefits, which meant he could use home health care. That provided help with household chores and meals.
I don't look at it as a handout. I just looked at it as just some help. And everybody needs a little help every now and then. And like now, I could still use the help. And they took all that away from me.
Under the COVID emergency declaration, Hairston couldn't be removed from Medicaid. But once that ended, the state reported that he made too much to qualify. That happened a few months back.
I don't see how I make too much when my income, when I worked as a coal miner, I had a great income. And when I got disability, the income is nowhere near what I was making. What I get a month, I was getting that in about like a week. It's just unbelievable. It's a real hurting feeling, and I've worked to go provide a good living for my wife and kids, which I have one that works, Karina. I have my other daughter, Colleen, which is a student at Marshall University and to become an OBGYN. And it's kind of hard for them it's hard for me to look at it and say, well, you cut me off and I didn't bring this pain and all this stuff to myself. It's just, I mean, I love what I was doing and I missed it so bad. And I still had a lot of good years left in me. And I see people cutting their eyes looking at me. You know, some of the people that I grew up with, they'll look at me, and even when I'm at church, the way I walk, I don't want people to feel sorry for me. I just try to do the best that I can do. But that right there, it speaks in volume.
Pointing to your helmet.
Yes.
Hairston says he never even got a letter saying he was disqualified from Medicaid. He found out from the home care organization he used. It's called Right at Home. They said the state wouldn't pay for any more services. It's a nationwide franchise, and in West Virginia, most of the company's business comes from Medicaid patients. Eric Hicks runs the company's local offices. He says when the government stops paying for a person's home care, it puts families in a bad bind. Most times, they'll try to find friends or family to help out.
And if that's not available, the only other alternative would be that person to potentially go to a skilled nursing facility under Medicaid and receive care in that environment, which is absolutely not where they would want to receive it.
When I asked Eric what Medicaid really gives someone like James, the answer is simple: autonomy.
There is absolutely a place for skilled nursing facilities and the services that they provide. When a person graduates from in-home care, that's where they go, because we cannot meet all their needs. But it's that gap in between that people want to stay at home, and they have the ability to stay at home if they have a little bit of assistance. People in general want to be in familiar surroundings. They want to have all their things that they have at home and not be forced to leave their home to go to a place that they're not comfortable with. A lot of people are more private. They really don't want people coming in and out of the rooms on a regular basis. They don't want to be in a more institutionalized setting. They want to be able to comfortably have as many of their family and friends over to visit whenever they want to come by, not be restricted by time constraints, etc.
Plus, Eric says there's research that says home care is good for the family and the state's bottom line.
It's estimated that the average person that receives care in the home, it will cost about $25,000 a year, whereas to put that person in a skilled nursing facility, the average cost is $95,000 a year. So there's a big cost savings there. And also what I was going to say is that when you look at the way that the federal match on Medicaid works, 74 cents of every dollar that we spend to keep a person at home comes from the federal government. This is a subsidy that us as a less affluent state receives from the federal government to help this. So really, when you look at almost 75 cents of every dollar comes from the federal government, this is an investment in our state so that we have people, so that it's funded, and that money goes back into the state, into our coffers, because these people are spending money in our state for goods and services that they need.
And when people can stay at home for longer, that offers better health outcomes.
There's always a cost component. I mean, there's finances involved in everything. But it is a quality of life, and it's being able to age in place. And if we can allow people to age in place, there's better longevity. It saves us money. They're happier. The families are happier. The families also, a big thing is it allows the families to go and be productive citizens in society and continue to work. Whereas right now, many of those people are stressed out because they're trying to take care of mom or dad and take care of their family, and many times their children, and they get sandwiched in between. So the stress level really increases for them. There's anxiety, and it causes a lot of friction within the families when you don't have something set up to allow people to receive the care at home.
In other words, autonomy matters.
As far as us and them, I think that, I don't know if it's a us and them, I think everybody wants this. Everybody understands that it's less expensive. Everybody sees the benefits of this. But once again, we have to, as a state, set our priorities.
At the end of the day, are we a country that believes in providing health care?
That's Tricia Brooks again from Georgetown University.
We could not have created a more complicated health insurance system in the United States. You put on top of that a means-tested program that generally serves low-income people who, by the nature of the fact that they are low income, they're likely to have lower education level, they're likely to have more stresses in their life. It makes it very difficult, if not impossible, for some people to get enrolled and stay enrolled. Let me turn the conversation for a moment. We have a healthcare crisis in this country with people with multiple chronic conditions. And there are more people, lower income individuals, who have multiple chronic conditions. And we fill up the pipeline of adults with children who have conditions rooted in childhood. And we don't provide them with the health care that they need so that they can enter school ready to learn, have higher performance in school, and come out on the other end as healthier adults, better educated adults who can break the poverty cycle and not necessarily have to rely on public programs in the future. We got to back up, go upstream and nip the bud here sometime. I've been doing this for more than 30 years, and we've been talking about bending the cost curve since the 90s. And we aren't bending the cost curve. We just keep filling up the pipeline with people with multiple chronic conditions. We need to start managing those chronic conditions so that people are healthy and can be productive workers.
But Brooks says there are real lessons to learn from the COVID emergency, not from the dysfunction of that moment, but from the positive impact of expanded healthcare access.
We achieved the highest rates of health insurance in this country on record as a result of the continuous enrollment requirement in Medicaid during the pandemic. And now we are, backtracking. And how far back we're going to go remains to be seen. But we are seeing glimmers of light, Trey. I just want to make sure that we talk a little bit about the positives. I think there's much more recognition of what we call administrative burden, red tape barriers to coverage that may be getting more attention, certainly more attention from journalists and the media. And here's a really, really bright spot, and that is that recognizing the importance of continuous access to health care, particularly for young children, we now have a dozen states working toward multi-year continuous enrollment for children. Washington State has already implemented it. Oregon is right behind them. And you've got New York, California, North Carolina, New Mexico. You've got a number of states moving in that direction. And that, to me, is one of the silver linings of what's happened to coverage in this country during the pandemic and now afterwards that Medicaid is being reevaluated.
And while those efforts continue, Brooks says states need to work even harder to ensure that as many people as possible who are truly eligible can get Medicaid.
We haven't spent a lot of money on outreach. Somehow we think that, putting up a website should be able to do it. But we need to make it easier for people to get enrolled. And as long as we aren't removing all these barriers to coverage, then we really need to boost the funding that community health centers get, support community-based organizations, and other organizations that can really provide the personalized assistance to help people overcome the barriers. The more people who understand about the barriers that people face in accessing Medicaid and CHIP, I think the more willing they are to consider how do we make the system easier to maneuver.
I started this story with a straightforward question. How does America survive a pandemic with less access to health care rather than more? The truth is, we could spend years making an entire podcast series on just this subject. How we make healthcare available is a combination of tiny little rules and big, sweeping political ideals. But as far as this moment goes in public insurance, maybe the question answers itself. We get less access by choosing to let that coverage unwind, disenrolling millions of people along the way. Returning to a so-called normal with more bureaucracy leads to fewer healthcare options for low-income Americans. You've been listening to Us and Them. Our team for this show was me, Trey Kay, Christina Stella, and Kate Smith. Special thanks to Martha Carter. Michael Lipton, Tristam Lozow, and Ahmad Solomon wrote and performed the Us and Them show music. Mark Lerner designed our logo. The marvelous people at PRX and West Virginia Public Broadcasting make Us and Them possible. So do grants from the Corporation for Public Broadcasting, the West Virginia Humanities Council, and the CRC Foundation. Hey, we'd love to get your thoughts about this episode. Would you share them with us on our Facebook page or on X, which is formerly known as Twitter? Go there at Us Them Podcast. Us and Them was originally developed with assistance from the mentorship program at AIR, the Association of Independents in Radio. We'll see you next time on Us and Them.
Support for this podcast comes from the Corporation for Public Broadcasting.